Mr. Yogendra, you can remove this in the meanwhile so that we can see everyone. Otherwise, we won't be able to
Okay,
see.
this is
Okay, ma'am.
Yeah,
Akriti ma'am, please stop sharing.
yeah.
30 now, ma'am. We can start.
Yeah, we can.
So a very warm good evening to all respected panelists and delegates. This is Firoz Khan from Walter Bushnell marketing team. On behalf of Walter Bushnell, we welcome you to this live webinar on the X-Files in PCOS under the aegis of Uttarakhand chapter of ISAR, that is the Indian Society of Assisted Reproduction. So without any further ado, I hand over the session to Dr. Akriti to initiate the proceedings for today's scientific program. Over to you, Akriti ma'am.
Thank you so much. I would like to welcome all the faculty, all respected seniors, and all the participants and delegates. This is ISAR CME organized by the Uttarakhand chapter on the occasion of PCOS Awareness Month, and I would like to hand over the mic for Dr. Aarti ma'am to proceed further. Aarti ma'am.
Thank you. Thank you, Akriti. A very good evening to all our senior friends and colleagues. It's a pleasure to have this webinar on the occasion of PCOS Awareness Month. And I'm so delighted to have with us our dear Dr. Durusha, President of PCOS Society of India, and Dr. Sujata Kar, Honorary Secretary General, ISAR National Chapter. Without wasting any time, I would like to invite Durusha ma'am to share her words of wisdom. When I had a word with ma'am today and I told her, ma'am, we are going to have this webinar. So her message was that create awareness amongst the masses, because the doctors already know a lot. So, that has given me a lot of ideas. Maybe within this month, we should have one or two more activities, a PCOS awareness walk and a school program. Ma'am, I'll assure we'll plan 2 public activities also in September to raise awareness. Over to Durusha ma'am. And before that, I would like to introduce ma'am briefly. Can I have ma'am's slide? Although
Yes.
all of us, we know ma'am so well. We've been reading PCOS newsletter regularly, and each time I look forward to reading the PCOS newsletter. Dr. Durusha is Director, Gynec World, the Center for Women's Health and Fertility, Mumbai, India. Ma'am is the founder president of the PCOS Society of India, an association which regularly sends news reports, health articles, and very active in sharing all the latest happening in PCOS, be it adolescent PCOS. I read a beautiful article in last newsletter, or be it PCOS related infertility management. Dr. Durusha has been founder trustee at Women's Empowerment Foundation. And ma'am's CV is so inspiring. When I was going through, she has been the member of Executive Board Aspire, and she's International Advisor, SIG Ashray Group, and she's the member of Editorial Board at TOG, RCOG, and Climatric, IMS, GHRS, ISA. Ma'am has published over 150 articles and chapters in international and national journals. And ma'am runs ICOG accredited fellowship courses at Gynec World to train young gynecs for fertility management. Ma'am has been past president of all the prominent organizations like ISAR, FOGSI, IMS India. And since our PG days, we have been seeing ma'am so active that her energy is superb, and she is one personality, to look forward to when you want to do good work in the field of OBGYN. Ma'am has been honored with Honorary Fellow of Royal College of Obs and Gynecologist, and she's been bestowed upon by FIGO's Distinguished Merit Award for services towards women's health. She's got Mahatma Gandhi Award 2021 for social responsibilities and gender equality. And she's got Black Swan Award for women empowerment. And Dr. Durusha has been awarded the Midday Powerful Woman 2022 for iconic gynecologist and fertility expert. Amazing achievements, and it's a pleasure to have Dr. Durusha with us and share her views on how to improve and how to provide the best care to uplift the women's health in our country. Welcome, ma'am. We can remove the slide so that we can see ma'am. You can stop sharing the screen.
So thank you very much, Aarti, for having invited me for this Uttarakhand chapters program related to PCOS. And you form one of the groups of ISAR. And yes, I was president of ISAR a few years ago and tried to do best whatever I could do for every organization which I headed. So there have been sort of, certain issues I brought up whenever I was president, and managed to get them into the lay people's benefit, in short, into the benefit of women at large having that problem. So for ISAR, actually, what we did was we tried to get insurance done, bringing infertility into insurance. And I met with the central government, and finally we got it passed that infertility should be considered as a disease, and therefore it should be brought under insurance. And there are already 3 to 4 insurance companies who are supporting infertility management. So I think these are areas where we as presidents should be doing something for our members, and we must do something for the lay people also. So it's very important for us to do that. And in short, when I got your invitation to talk about what really is the, to be the chief guest for your PCOS program, I read that you have something called today the X files in PCOS. The X files in PCOS is because in the past it was called Syndrome X. Okay. PCOS was called the Syndrome X, and it was something which was labeled for a long time. And we did the first conference on Syndrome X in Goa in 2008, which was a huge success because everyone loved going to Goa. And we did it in collaboration with the Androgen Excess and PCOS Society. So it was the first beginning of talking about what really is PCOS. It was a lot of new things which were brought to us by the international organization. But since then, it was 10 years, and in 2018, we got the guidelines on everything about PCOS. And I was lucky that we could get the PCOS Society to be one of the societies, who was involved in the making of the international guidelines. And I was invited in my personal capacity to be one of the members of one of the groups to work on those. And we did do a lot of, what we call promotion of these guidelines so that we could update all the doctors all over the country. And we had webinars. This was even before 2020, in 2019, before any such webinars were being held, before Zoom was in place. We did webinars, and we did it on the international guidelines. We distributed guidelines to all the 35,000 gynecologists the country, and it was a way of updating our doctors on what is new about PCOS. So the diagnostic criteria changed, the management changed, and now 5 years later we are working on the 2023 guidelines. So those will be released next year, and we have already started working on those, as I'm a member of that committee too. So in short, today when we are talking about PCOS, I find there's a lot of awareness. As a matter of fact, I feel so happy when I see a PCOS program. I feel my job is done. I mean, I started only because I felt that we need to focus on this, because this condition affects girls right from adolescence up to post-menopause. And we have been in all our conferences talking constantly about it. We just finished this annual conference just this last weekend. And it's something which we need to address. And today we need to go into a preventive mode. And that preventive mode will happen when we reach out to our. And I think it's extremely important, and that's my agenda for next year. Reaching out to our patients in a proper systematic manner, as we have done earlier for young people, for their reproductive sexual health. For almost 10 years, we reached out through the Growing Up program. to all young people in schools and colleges everywhere. And 2006, when I was the president of FOXY, I brought in the theme of the youth, Year of the Youth. It was called 2000 Year of the Youth, making the majority our priority. With lot of going to school, we did. There were at least 1,000 gynecologists all over the country who helped me in this agenda. But today, adolescent today has become very popular. Lot of people at FOXY there's an adolescent committee. They are doing a lot of work, and I think soon with PCOS also, hopefully in another few years, because we are still a small, not small, sibling society since 7 years, but we have got about approximately 1,500 members already. And we are a multidisciplinary team. We have gynecologists, endocrinologists, everyone who handles PCOS women. And therefore, I don't know how many of you have seen our W3 webinars. I don't know how many of you came for the conference, but Sujata is here that she conducted a brilliant workshop on basic infertility care. We have done so many webinars where we have multidisciplinary people, and that is what we need to do. We need to learn from the other disciplines on how to take care of PCOS girls, PCOS women, and now preventing PCOS in a pregnant woman so that her child is not born with PCOS. That should be our agenda. Well-known fact that PCOS women it's not genetic transmission, but it is because genetic transmission is hardly 5 to 10%. But it's the environment in the mother's womb, that of hyperandrogenemia, hyperinsulinemia, all that needs to be corrected before a woman gets pregnant. And that is something I'm still not seeing happening. I'm not seeing infertility, care being given after these areas are corrected. I've seen a lot of people just jumping into IVF care or just offering IVF to patients even before the insulin resistance is corrected, or even before the sugar is corrected, or even before, any kind of, prenatal care is given to that girl before going into IVF. So I only appeal to you now, since you're representing the officer, that please pass the word to all the fertility specialists that it's important for us to make the environment within the womb of the mother to be, clear of all the hyperandrogenemia, all the insulin resistance before they put in the embryos, so that the baby grows in an environment which is not full of male hormones, not full of sugar, and these babies should not in future develop PCOS as it happens today. So I think that is the message I want to give, that let's start at the preventive stage. We being the gynecologists treating these women, we are the ones who see them before they get pregnant, and it's important for us to do that. So that's the only message I would like to give as president of the PCOS Society of India. And I see a lot of friends here. I see Akriti, who's part of the Youth Brigade, very, very active. And I'm happy to see here. I see Amit Patki, a colleague of the Secretary General, the president of FOXY, and we did a great team together. And I think a lot of you whom I've met before. So all the best to you for your program today. You have a great meeting. You have 2 great speakers and then a panel discussion. So thank you very much for having me here with you, and I wish you all the best. Thank you.
Thank you so much, ma'am. All the points which you have quoted, they are of utmost importance. I never thought anyone would go to the TPA facilities for not giving cashless to infertile patients, because till today the patients would request, ma'am, please make one discharge in which you don't mention infertility. I didn't know that we can take steps in this field also, because it's really the sore point on the part of patients that they don't get their facility of cashback if they are infertile. I mean, that's a great work which you have done. And of course, preventive aspect, we are going to promote it more and more. And we welcome Dr. Amit Patki, our incoming president, ISAR. And in fact, Dr. Sujata Kar had suggested that, Karti, this is PCOS Awareness Month. So let's have a very good webinar with you, ma'am, as chief guest. Thank you so much for being with us, ma'am, despite your busy schedule.
Thank you so much for having me.
Very inspiring that, ma'am, you're doing a busy evening OPD also. Like, I was imagining your working hours because everyone works in the morning hours, but you run a busy evening OPD. That is amazing. More energy to you, ma'am. Thank you so much.
Thank you so much. Thank you. Bye-bye. Bye.
Thank you, Dr. Amit, for being with us, and sorry for the early morning texting also. And thank you, Dr. Sujata, for this great idea. And before we start the academic program, Dr. Sujata, the Secretary General, and Dr. Amit Patki, the incoming president, is with us. And Dr. Nandita is at the airport. She is going to join us very soon. She said, Aarti, let me do security check, then I'm going to log in and I'll be with you till the time she boards the flight. Can I quickly give handover to our incoming ISAR chairperson? I would like to briefly show the activities done, and then Sumita, a very able, dynamic infertility consultant from Dehradun. I wanted to pass on the baton to Dr. Sumita as the next chairperson for ISAR. Can I share my screen, Dr. Sujata, and quickly? Dr. Sujata, I think you're muted.
No. I have to start the lecture.
I'll take 5 minutes to give over to so
Right.
Dr.
Right.
Fine. Yeah.
Perfect.
Okay.
But we didn't see Dr. Sumita. She's there.
She's here.
Good evening, Dr. Sujata.
Yeah, good evening.
So are my slides visible?
Yes, ma'am.
Yeah.
So the Uttarakhand chapter of ISAR, it was started in 2018, and it was the initiative of Dr. Rishma Dhillon Pai and Dr. Rishikesh Pai, who pushed us that why not Uttarakhand also start with ISAR activities. And it was their inspiration and motivation that we started this chapter in 2018. And Dr. Rishma Pai was here to physically inaugurate and start the chapter. And the topic was journey of ART, which she spoke on, and the theme of our meeting was advances in infertility, and the chapter was started with great zeal and good attendance. And there then started the series of activities. We had health programs, we had lots of physical meetings. So December, we organized health awareness camp for school children at Sneha School. Then February, we had a CME, and then again, we celebrated ISAR Day in February, and we organized a mammoth walk. The topic was Walk for Hope, and it was the national initiative that all the societies had to organize any activity along with free camp. And all the societies and doctors, they organized free camps also. Then came ISAR Mumbai, where our society represented very well, followed by we organized regional state chapter conference in July 2019, where we had national speakers like Dr. Neelam Ori from Varanasi spoke on advances in endoscopic surgery, and Dr. Preeti Jindal from Chandigarh, she spoke on how to improve IUI success. And there was good participation by faculty from AIIMS Rishikesh, Haldwani Medical College, SGRR Medical College, Himalayan Institute, and all surrounding Uttarakhand societies. So this meeting was appreciated well. This is our ISAR's participation at National ISAR, where we can see Dr. Amit Patki with us also. There was a gorgeous tree plantation drive, and there was a lot of work on setting up guidelines for role of Dufeston, in which Dr. Patki had shared his views because he has worked a lot on dydrogesterone. This is another activity. We organized health camps, and this is Dr. Ritu, our secretary, who was very active in organizing most of the activities in Rishikesh and surrounding area as part of ISAR Uttarakhand team. And this is another CME where we can see all the senior members participating with great zeal. Then we organized one workshop on IVF in ART. We can see Dr. Sumita here, Dr. Ritu, Dr. Luna Pant from Max. Another meeting, and we had a very good tenure with lots of activities and physical conferences. And we had the pleasure of having Dr. Sujata Kar with us as a part of travel seminar. And we had invited Dr. Neena Malhotra also. And then came the COVID after March. And there was, when we had March, there was ISAR Hyderabad. Everyone was there with great excitement. And just after ISAR Hyderabad on 7th March, the government of India declared lockdown in second week of March, and then started our series of live webinars. And even in the first live webinar, which was on 21st April 2020, we had discussion on laparoscopy on 2020 post-COVID, because everyone was so scared of doing laparoscopy in COVID time due to the aerosols. And we had great speakers with us like Dr. Sonia Malik, Dr. Osama Shauki, Dr. Sunita Tandulwarkar, Dr. Nikita, and the best from India and abroad. They were participating in ISAR webinars. And that's how the X file started, because we were having very interesting topics. So this is X file in OBGYN. We had talks on endometriosis, hyperandrogenesis, and we had great speakers like Dr. Pranesh Shah, Dr. Sarita Shyamsundar, and Dr. Ganatra, and again the X files. And this series continued with great zeal. And every week we were doing one webinar, and we were having great discussions with national speakers like Dr. Tank, Dr. Alpesh Gandhi, Dr. Prakash Trivedi, Dr. Naren Malhotra, and the exchange of knowledge continued. And this is like very regular July, August. So Uttarakhand ISAR continued lots of national webinars all through 20 and 2021. And then when the lockdown got over, we had a walkathon again in March 21 to raise awareness about infertility. And this is again the series of webinars with all the senior people like Dr. Atul Ganatra and Dr. Alka Pandey. And you can see all our participants from Dehradun. Dr. Sumita is there, Dr. Luna is there, Dr. Vinita. They are all our ISAR members who were very actively involved in all the activities. Even now, Uttarakhand represents at national ISAR meetings. Lots of people attended Yuva ISAR Kolkata and ISAR TOG. Dr. Rima was there at annual ISAR Mumbai and Yuva ISAR Jaipur also. We had a good representation. And I'm very happy to pass on the baton to Dr. Sumita, a very good friend and very enthusiastic clinician. The only thing which I regret is I had been trying, and I was very keen that Dr. Sujata and Dr. Nandita should be physically present with us when we do the change of chairmanship. But it's so good to see both of you, Dr. Sujata and Dr. Amit, virtually only. And I'll invite Sumita to say a few words, and then we'll start with Dr. Sujata's talk.
Thank you so much, Dr. Aarti. You've put a big responsibility on my shoulders. And thank you, Dr. Sujata. It's a pleasure that this changeover is happening in your presence, though it is virtual. And me and Akriti and all the team members of Uttarakhand ISR would try our best that we keep up to Dr. Aarti's wonderful work which she has done over the years. And we'll continue our efforts to improve the status of infertility in our tiny hilly state of Uttarakhand by raising awareness and also trying to improve the facilities of infertility. I think I'll not take too much of time, and thanks again, Dr. Aarti. And again, I will request Dr. Sujata to continue guiding us during her tenure and give her blessings to Uttarakhand ISR chapter. Thank you so much, Aarti.
Mr. Yogendra, can we have Dr. Sujata's CV and Dr. Akriti will invite the chairpersons to introduce Dr. Sujata?
Okay, ma'am. Yes, ma'am. Ma'am, Sumita ma'am is the chairperson. Ma'am, you please introduce Sumita ma'am.
I welcome Dr. Sumita as chairperson of the session, and she's well known to Dehradun Society, and she's director at Care IVF Unit Dehradun, and she is running Can Protect Foundation for doing work in remote areas of Uttarakhand. Can I have Dr. Our another chairperson is Dr. Oli. He's also a very active ISRN. He's director at Oli Hospital, and he's practicing infertility for many years. He's been vice president UK ISA. And can we have Dr. Sujata's slide, and Dr. Sumita will introduce Dr. Sujata. Dr. Sumita, can you see the slide? You're muted, Dr. Sumita.
Okay, yeah. So I welcome Dr. Sujata, and she's a very well-known figure in the whole fertility, infertility circuit in all over the country. She's presently practicing gynecologist, endoscopic surgeon, and assisted reproduction for last 25 years. Her special areas of interest: polycystic ovary syndrome, proteomics of male infertility, and scope of stem cells in gynecology. The major achievements and honors: she got her breast graduate and 7 gold medals in MBBS and MD. She's accredited with first IVF baby in Eastern Orissa, first TISA, frozen embryo and laser hatching baby in Orissa, POIA best IVF center in Orissa for the last 2 years. Not very clear. Okay, Parichaya Award for Women Achiever Orissa 2019 from Honorary Governor of Orissa. Devi Award for Dynamic and Innovation from the Chief Minister of Orissa. Brand Icons Excellence Award 2018 for Best IVF Center in Eastern India. She has already published 15 original publications related to PCOS and male infertility in PubMed. She has written many chapters for books and newspapers. She is reviewer of many international journals. Currently, she is the honorary treasurer of ISR India. She is elected member of ISH, ISSRF, PCOS Society, and Fertility Preservation Society of India. Welcome, Dr. Sujata, and I think we can now have her presentation.
Good evening, dear Aarti, and my dear friend Dr. Amit Patki, and our incoming president. Dr. Nandita hasn't, I think, checked in yet, but she's been my president for the last 6 months, and I've been enjoying working with her. And it was a real pleasure to hear, those golden words from Dr. Durusha. She's so enthusiastic about whatever she does, and it's always been a great pleasure to, work with her. I have worked with her during this hour, so it was great. And Aarti, I can't imagine you have always been a pro where organizing workshops, meetings were concerned, but after seeing this entire big list, I am amazed and so proud. And you are always very perfect, politically correct, organizing correct. So, it is a great pleasure to see how much activities Uttarakhand has been doing. And yeah, Dr. Sumita, I welcome you as the next chairperson. I'm sure you'll do a great job. And
thank you so much, ma'am. We'll need your blessing.
Yeah, but I'm sure with Aarti around and all of you together, it will continue to be as good as it has been. And me and Dr. Nandita, we are just wanting to come as early as possible and meet you all. We've been trying since April, right, Aarti? But it's not been happening some reason or the other. So I'm sure it will happen. So I think now let's get to business and to talk. So the talk that has been given to me is about the updated criteria of the diagnosis of PCOS. Now, you will all agree that there is an epidemic. In fact, there's a pandemic of metabolic syndrome as well as PCOS. The way we see so many patients in our OPD. Now, even we are seeing many adolescents and young girls so often and so many. So before branding anybody as a polycystic ovarian syndrome patient, because then it carries with it a long-term, sequelae, outcome, long-term management, and she gets branded with PCOS. We have to make an effort to make a proper diagnosis of PCOS. That is the first point that I wanted to say. Now, over the years since 1990, 2003, Rotterdam, 1990, the NIH definition, and today we have the new international guidelines of PCOS. We've come a long way, and mostly it has been a ASRM and ASHRAE effort over last many years. But this time that we have the new international guidelines, which is excellent, it has involved so many countries, all the continents were involved, so many countries, all the societies, all the specialities. So it is a huge document, and we are really grateful for it that today we have the new international guidelines to fall back to understand most of the things about PCOS. Now, NIH had two criteria, the chronic anovulation and hyperandrogenism, either clinical or biochemical. Rotterdam added the polycystic ovarian morphology by ultrasound. Now, we know all the criteria of the polycystic ovaries, and the Rotterdam told us that at least two out of these three will constitute polycystic ovarian syndrome. Now, over the last 20 years almost of Rotterdam, we have realized that it overdiagnoses PCOS by almost 50%. And most importantly, it does not take into account the effect of age, ethnicity, lab testing, use of various medications like oral contraceptive pills or metformin, etc. We know that there are 4 phenotypes from Rotterdam. 3 of them are the hyperandrogenic component. They have hyperandrogenic component. One of them, the phenotype D, does not have the hyperandrogenic component. It is polycystic ovarian syndrome, polycystic ovarian morphology with anovulation. So I just want to, make you think of the 4 criteria. Let us look at polycystic ovarian syndrome, PCO ovary, and anovulation, which is the phenotype D. Is it possible that in this situation, we are not testing for androgens? Is it possible that the biological limits of hyperandrogenism in this category of patients is not being tested by us, or we are not testing it correctly? Is it possible that the 25-30% of women who have polycystic ovarian morphology but are completely normal, we know that that happens, and they have normal ovulation, they are normal fertile, but on ultrasound they have a polycystic ovarian morphology. So is it possible again that we are not able to test their hyperandrogenism, or is it possible that the existence of polycystic ovarian morphology is only a coincidence and it is not at all a disease? And also for hyperandrogenism and anovulation, in which there is no polycystic ovarian morphology, is it possible that we are not testing the polycystic ovarian morphology correctly? So there are many problems with Rotterdam criteria, with its phenotype, and in fact, many people have suggested that it should be called Rotterdam criteria, and it is high time that we completely got rid of it and started rethinking about defining polycystic ovarian syndrome. In fact, by the Androgen Access and PCOS Society, for a long time, there was a lot of discussion about changing the name of PCOS, because it is a very misnomer that it is, because we are still not sure whether the original problem is in the ovary, and there is no cyst in the ovary, there is no pathologic cyst. So the name polycystic ovarian syndrome itself may be inappropriate, but then we haven't progressed much on that. So today in my lecture, I'll cover 2 parts. One is, can AMH become a new diagnostic marker? Because we need a proper diagnostic marker. And 2, critically evaluate each of the 3 Rotterdam criteria, because the new international guidelines tell us that yes, all the 3 criteria are fine. The hyperandrogenism needs to be checked, anovulation needs to be evaluated, and polycystic ovarian morphology may be a part. Whether AMH can be added and whether all the criteria needs to be updated, that is what we need to decide. Now, AMH, of course, is becoming a very important part of defining the pathophysiology of PCOS. Whether it is just a marker or it is involved deeply in the pathophysiology. I will not have to have the time to go into the pathophysiology, But we know that the AMH increase in PCOS is not only because there are more number of follicles. It is also because each follicle secretes more number of AMH. So there is some pathological secretion of AMH also probably at a intrafollicular level, and the AMH is probably likely working at the intrafollicular level to lead to a situation where there is the conversion from androgenic to estrogenic, estrogenic to androgenic value does not happen. The follicles do not express FSH receptors, and thereby they are completely suspended in time. That is what happened in polycystic ovarian morphology. Normal functioning, highly sensitive follicles who are capable of ovulation completely frozen in time. So AMH is an important marker, no doubt, but the problem is that we are having difficulty in determining cutoffs and to standardize the assays. Currently, we have many assays, the reproducibility, the cost, and the standardization has not been very, up to date, and it has not been very satisfactory. That is why we are not able to find cutoffs. And also we are not able to define population-based cutoff and age-based cutoff. It is not easy to just say that in Caucasian population, this is the AMH level. And so that doesn't hold true for India. Even in our country, we don't have any cutoffs defined as yet, but it has to be age specific also, because the cutoff level at the age of 20 will be different at the age of 35. And moreover, there are a lot of ethnic and racial variation. That also needs to be taken into account before AMH can become a standardized marker. As you can see, many publications from different countries, there is a, this thing, I'll show you that. So there are various cutoffs from various ethnic groups. In India, Nalini Mahajan and group showed 5 nanograms as a cutoff level in our country, and Asian countries, Caucasian countries, China, they have all come up with different cutoffs. So we are simply not at a stage where we can choose serum AMH as a diagnostic marker of PCOS. Now let us look at all the 3 criteria. What are the problems with polycystic ovarian morphology? We know that the new guidelines, international guidelines, all these years we used to follow the Rotterdam criteria. And Rotterdam criteria made so many radiologists just give a diagnosis of PCOD, PCOS, and things like that. But there was a clear-cut definition of how to define that. But today, with the newer onset of ultrasounds, etc., we have very high ultrasounds with very good clarity. And so the newest definitions, as by the Androgen Axis Society, decided that the polycystic ovarian morphology should be more than equal to 25 follicles per ovary. The ovarian volume remained as 10. But the international guidelines took it as 20. Now, if you look at some of the publications in the last Dr. Nandita has joined in.
Yeah, hi.
Hi. Welcome. I was just giving my lecture almost halfway.
Sorry.
Not at all. So we can see some Asian data which have totally different cutoffs of follicle number per ovary. Even for example, in Korea, they had a cutoff of around 14. Turkish had only a cutoff around 9.8. They all using 3D ultrasounds. Chinese, they gave a cutoff of around 15. I published from India, and we gave a cutoff of Indian PCOS women using 3D ultrasound of only 10 follicles and a volume of about 7 centimeters as a cutoff for deciding polycystic ovarian morphology in PCOS. I think some other. Yeah. So, and then this was a fantastic paper in Human Reproduction, which showed that AMH, polycystic ovarian morphology, and age, all 3, if they can be combined, and then if we can come up with some diagnostic criteria, that would probably be the most accurate. To define that, we'll also have to take into account ethnic and racial variations, as this beautiful Chinese paper has shown that at the age, in younger women, the follicle number per ovary in their population was 12, and the serum AMH was 5.5. and an anti-follicle at the age of less than 30. And in older women, the follicle number per ovary was around 10.7 and AMH was about 5. So the thing is that we do not yet have a polycystic ovarian morphology criteria, although international guidelines tell us it should be more than 20. But we should take it with a pinch of salt, because in our country, in our race, it might be totally different. In our ethnicity, it might be totally different, like many publications are showing. And therefore, also another point is that the new international guidelines in their diagnostic criteria completely undermine the role of ultrasound for the diagnosis of PCOS. And most importantly, in the adolescent group, it is important that we do not use ultrasound, and we very sparsely use ultrasound only maybe when we don't have clinical evidence of hyperandrogenism. In that case, we might consider using it. So that is about ultrasound criteria. We know that Indian women have lower anti-follicle, lower AMH compared to Caucasians. So the data that tells us to take 20 as an upper limit of follicle number per ovary is based totally on Caucasian data. So that is the point that I was trying to make. Now, the next criteria for polycystic ovarian syndrome is anovulation, which is the simplest, easiest to define. We know that in the first year post-menarche, almost any kind of abnormality is normal, or primary amenorrhea up to the age of 15, or after 3 years post-thelarche. These are the criteria which we should take to define anovulation. So anovulation for the first year post-menarche should be considered normal. It should be considered as a transitional phase. If there is primary amenorrhea up to 15 years, one should evaluate for PCOS also. If there is amenorrhea after 3 years of thelarche, appearance of breast development, then one should start considering. Even early adrenarche has to be taken as a sign, possible sign of PCOS. 1 year post-menarche, if there is any amenorrhea lasting more than 90 days, that has to be considered abnormal. And after 1 year and less than 3 years, this is the criteria set to define anovulation. After 3 years, then the adult criteria is applied, which means any woman or any girl who menstruates less than 8 cycles a year is to be considered anovulatory. So that was about anovulation. Now, the next is about hyperandrogenism. That is now like polycystic ovarian morphology, another very difficult area to define, clinically. Let me know how much time I have left. I think this is a 15-minute this thing. Yeah. So hyperandrogenism is, or hyperandrogenemia. The first is about clinical signs. It is very difficult, and especially when young girls are undergoing epilation so often, removing hair for their, appearance and all that. It's very common. So clinically, when we see a patient of anovulation and we want to say whether she has clinical hyperandrogenemia or not, it is rather difficult. But if you go by the book, we are supposed to do a Ferriman-Galway score, which should be at least more than 6 or 8. The modified tells us it should be more than 6. You should look at the hair growth. Terminal hair should not be taken into, should only be considered, and villous hair should not be considered. If you are looking at hair loss, then a male pattern hair loss can be categorized grade 1, grade 2, grade 3 in this manner. And there are no visual scores for acne. But in young girls, severe acne, which is long-standing and which does not respond to treatment, because in adolescent age group, again, it corresponds to features of puberty, so we have to be careful. But in an adult woman who has crossed puberty, if you find severe acne, those who do not respond easily to treatment, or for whom it has newly appeared, all these things have to be taken into account. Clinical hyperandrogenemia, again, we know that it is PCOS is a clinical syndrome. It should be mostly diagnosed clinically. So the requirement for doing a blood test to detect hyperandrogenemia should not generally arise. But in case we can do, the only reason why we might do is to make a diagnosis of PCOS in a woman who has anovulation, also maybe has polycystic ovarian morphology, but has no clinical evidence of hyperandrogenemia. For example, she does not have, at least she doesn't report excessive hair growth, she doesn't have acne, etc. In that situation, to make a diagnosis, you might consider. But again, we have many issues as to which test we should be testing and which assays we should be going by. If we have to define by book, probably the best is a free testosterone. Next best comes a total testosterone. And the best assay method should be a mass spectrometry. Of course, chemiluminescence comes as the next best. But we must understand that even if we do these tests, they carry a lot of problems other than being costly. Their laboratory values are not standardized. They are not always reproducible. They are not always standardized. But the problem is that we do not have population-based cutoffs. For example, we all know that hyperandrogen, how to define hyperandrogen. Clinical, we know that it will vary even in our country between various different races, different ethnicities. The hair growth probably in the northern part of India, eastern part of India, western part of India would vary a lot. The FG scores in these regions itself, different ethnicities would vary a lot. And even if we look at, let us say, total testosterone or a free testosterone, we don't have any population-based cutoff. You will have to depend on the laboratory that says, okay, 72 nanograms per DL or something like that is the cutoff that you define hyperandrogenism according to our laboratory. So we do not have the age-based, etc. So it has a lot of issues. So by and large, it has to be a clinical and hyperandrogenism that has to be taken into account. And accordingly, we have to base our diagnosis of PCOS. So to conclude, I'll show you my last slide, which has been shown, which has been proposed by the new international guidelines. So basically, if you see a woman who reports to you with irregular cycles and has features of clinical hyperandrogenism, either acne, hair growth, male pattern baldness, acanthosis, or other features of insulin resistance, etc., then you have to exclude other causes. We know the other causes, at least a thyroid, prolactin, and if she has severe hyperandrogenemia, androgenism, then you could also test for CAH and other factors. If she has none of those, then you can make a diagnosis of PCOS. If there is no clinical hyperandrogenemia, only evidence of irregular cycles, then you might consider doing a biochemical test for hyperandrogenism and exclude other causes. And without doing an ultrasound, if these are high, you can make a diagnosis of PCOS. If there is only irregular cycles or only hyperandrogenemia or hyperandrogenism, in adults, you may do a scan. If there is polycystic ovarian morphology, you can make a diagnosis of PCOS. In adolescents, you don't have to do any ultrasound. If she has irregular cycles, along with evidence of hyperandrogenemia or hyperandrogenism, you don't have to have a scan to look for polycystic ovarian morphology. You can put her at risk of PCOS and then manage her accordingly. Thank you very much.
Sorry to interrupt, Sujata, but I'm boarding a flight, so I need to just.
Ma'am, we want to have President's note quickly. That's what
Yeah.
I was waiting.
Yeah, first of all, I would like to congratulate Sujata on a beautiful lecture. I think I really enjoyed it. Sujata, you speak with so much passion about PCOS, no? I think that should be the talk you should be giving. Aarti, first of all, congratulations. I think you've had a wonderful tenure with Akriti. It was fantastic and you've done such a wonderful job. And I think the Himachal chapter has really, you know, the Uttarakhand chapter, the Uttarakhand chapter has really been shining because of you. You have done wonderful, wonderful things. And the way so many CMEs and so many programs have been conducted, it is really fantastic. And I am really, the kind of that I did want to come during your year for the program, but it was just not possible. So I shall definitely come, and I want to wish Sumati all the best for her For
We would like to welcome you. You must come to Dehradun at least in this.
No, I will. I will. I have promised R3. So I have to try and make it. But it will be a pleasure, Sumati. And all the best to the new team. It's really a pleasure to be here. And I wish you all the best. And now that the law has come, I think we should really work very hard at it. There is the ESAR embryology, which is happening in November. And we are inviting a lot of people, and there will be discussion about the law. So I hope to see a lot of your people there. And also during the ESAR annual conference, please do send your people who are please do send the people who are wanting to come for the conference, who want to give lectures. We would really be happy to accommodate them. So Sumati and Aarti, please do the needful and send the names of all your faculty who are interested in talking. So thank you very much for inviting me here. And you can continue with the program and continue with questions for Sujata. Sorry to interrupt, but I am boarding my plane now. So I'm very, very happy to come here and, be there for your installation ceremony. Thank you. Thank you very much.
Thank you so much. Thank you so much.
Safe travels, and thank you for your very positive words, and hope to see you soon in a physical meeting. And we have lots of volunteers for Bhopal quiz and presentations. The list is already ready. They'll
Fantastic.
all be there. Yeah.
So please give it to Randir. He's looking forward to having you.
Yeah.
So it will really be a pleasure to accommodate everyone.
Yeah. Thank you.
Okay. All right.
Bye. Have a nice time.
Bye-bye. See you. Thank you. Thank you very much. Bye-bye. Bye.
Bye. Dr. Sujata, your talk was amazing, and you are a true scientist, like the research oriented, study oriented, which awakens the ideas that how to work up for a patient. I'll invite the chairpersons for their comments.
I think Dr. Sujata gave a very, very comprehensive talk and a very valid point that we need to have some Indian standards also. We don't have so much of data about what should be the exact cutoffs for our Indian patients, a very clear-cut guidelines for, diagnosis of PCOS, which is such a, confusing topic. And thank you so much, Dr. Sujata. Personal thanks for being here for this ceremony today and for your wonderful talk. If there are any questions, I think probably we can take them at the end of the session. Aarti, we can continue with the next talk.
Yeah.
Absolutely. Yeah. Akriti, let's invite chairpersons for the next session for Dr. Aditi's talk. So we have with Dr. Archana Luthra, who's also in transit. Ma'am is a senior gynecologist in Dehradun, and she's a life member of ISA from the very beginning. Can we have the next slide? Dr. Anupma, are you with us? Dr. Anupma, she is president, Rudrapur Foxy Society, and a very active, enthusiastic Foxy and ISARian, who is part of all our webinars and most of our physical activities also. If both the chairpersons are not around, I would like to introduce Dr. Aditi, our young brigade, a bright, bubbly, but very focused and sincere young IVF specialist. And she is the fertility consultant at Dr. Trivedi's Total Healthcare Center. I have visited your dad's center, Aditi, and you guys are doing great job. You, Somil and Prakash sir, the team is terrific, along with ma'am, of course.
Thank you.
Yeah. She's consultant at Jupiter Hospital, Mumbai, and Dr. Aditi has got fellowship in reproductive endocrinology and infertility and in minimal access surgery. And she's trained in cryopreservation and ICSI, and she's the managing committee member of Maharashtra chapter of ISA 20 to 22. She's published review articles in national and international journals, and her vision and motto is elevate to elevate, elevate fertility knowledge and treatments to alleviate fertility issues. That's beautiful. Welcome, Aditi, to Uttarakhand. It is, online this time, but we would like to have you here for a physical meeting and a holiday very soon. Over to you.
Thank you so much, ma'am, for such a kind introduction. And it's my pleasure that you invited me and given me this opportunity to present a talk in front of seniors and stalwarts like Nandita ma'am, Duru ma'am, Sujata ma'am, Amit sir. So it's my pleasure to be here. I'll just share my screen. So I'll be talking today on managing resistance to oral ovulations in PCOS. Now, this is a very common problem which we face in our day-to-day practice in treating anovulatory PCOS patients, especially those belonging to phenotype A and B. So it was a breakthrough when Mitwali et al. For the first time published letrozole, the third generation aromatase inhibitor, to use as an ovulation induction agent where there is clomiphene citrate resistance. So basically, we all know that letrozole inhibits the aromatase enzyme and it inhibits the conversion of testosterone to estradiol and androstenedione to estro. Now, this negative feedback of estrogen, lack of estrogen in the pituitary, it stimulates the secretion of the activins, which in turn stimulates the production of gonadotrophs, FSH and LH, and helps in folliculogenesis. So the first line of drug is definitely letrozole. The second option is clomiphene citrate, though there are very less reports regarding its improvement in ovulation and pregnancy rates because of its effect on the endometrium. Now, why does there is failure of ovulation with oral ovulations? And it is all related to the oocyte competence, which is affected by high BMI, raised LH levels, raised free androgen index, and hyperinsulinemia. So because of persistent high LH levels, there is altered activation of the meiotic process and meiotic maturation is affected. Because of increased androgen levels in the ovary, there is decreased calcium oscillation, which affects the epigenetic maturation as well as the cytoplasmic maturation. And hyperinsulinemia affects the follicular recruitment. So we have to go step by step in treating patients who are resistant to both letrozole and clomiphene with a standard dosage. So for the most important thing is lifestyle modification. Then there are various alternative protocols with clomiphene citrate and letrozole, along with usage of the adjuvants, gonadotrophins, whether we need to do laparoscopic ovarian drilling. And at the end, if nothing works, then we have in vitro fertilization. So let's go through each and every option one by one. So lifestyle factor plays a very important role. We all know that obesity, smoking, alcohol, all affects the fertility and increases the time to conception. So before treating any patient with anovulatory PCOS, the most important thing which you need to say is to improve their lifestyle, promote weight loss. And this is a very beautiful study by Walter et al., where they've clearly shown that early and consistent loss of intra-abdominal fat is associated with resumption of ovulation. So now we are at this crossroads where we really don't know which alternative protocols to be used because there are no standardized guidelines about what letrozole protocol or what clomiphene citrate protocol should be used in case of resistance. So there is step-up letrozole protocol, extended letrozole protocol, extended clomiphene citrate protocol, and tamoxifen. So let's go and visit each and every protocol, review each and the literature about each one of them. Coming to step-up letrozole protocol, for the first time, it came into mention when Mitwali et al. Presented this study in fertility sterility way back in 2008, wherein it was a very small group study of 9 patients. They had used letrozole in a step-up fashion of 1, 2, 3, and 4 tablets from day 2 to day 6 of cycle. And what they found was improvement in ovulation, multifollicular development, and a higher pregnancy rate compared to clomiphene citrate. Coming to extended letrozole protocol. Now, concept behind extended letrozole protocol is that what it does is because of extensive use of suppression of the estrogen, the FSH window is extended. And because of the extension of the FSH window, there is more recruitment of the follicles, resulting in multifollicular development and increasing the pregnancy rate. So Badawi et al. In 2008, they had published a study where they had compared, given extended letrozole to patients who are resistant to clomiphene citrate. And what they found was there was more number of ovulating patients with more mature follicles and subsequently resulting in a higher pregnancy rate. Fauda et al. Similarly studied extended letrozole compared to clomiphene citrate in patients undergoing IUI with unexplained infertility. And they also found this protocol to be superior than clomiphene citrate. Thomas et al. Compared ovulation rates in patients giving letrozole and clomiphene citrate in a step-up fashion. And this is a very good study where they published in 2019, where they found that the pregnancy rates were similar in both the protocols, but the time to achieve ovulation was shorter in the letrozole protocol, as well as the endometrium was not affected in the letrozole group. Coming to use of high dose of letrozole, Pritz et al. Had used letrozole as high as 12.5 milligrams per day. And what they concluded that was the higher dose, short-term administration may be more effective at inducing endogenous FSH release and resulting in a greater follicular development. Coming to extended clomiphene citrate group. Fluker et al. Had published a study way back in 1996 when letrozole was not available. And what they did was they used clomiphene citrate in an extended 10-day course, and they found it as an inexpensive and non-invasive alternative to gonadotropins when it comes to anovulatory PCOS resistant to clomiphene citrate. Further, Badawi et al. Had published this randomized control trial wherein they studied extended clomiphene citrate treatment, and what they found was the number of ovulating patients were comparatively less compared to the gonadotropin group. The pregnancy rate were also less compared to the gonadotropin group, but what they found was that it was not extremely less, and it can be used as an alternative because it is cheaper and economic with almost equal efficacy and safety advantages. Now, this was a very interesting paper published by Takasaki et al. In 2018, where they had mentioned the use of intermittent clomiphene citrate treatment for women resistant to the standard dose, wherein they gave clomiphene citrate 100 milligram per day from day 5 to day 9 of cycle. They monitored the patient on day 14. If there were no mature follicle, they repeated the clomiphene citrate for 5 more days. Again on day 23, if there was no dominant follicle achieved, they repeated the dose of clomiphene citrate. And here you can see that they managed to achieve ovulation in quite a number of patients. Though the lack of study was, they did not mention about the clinical pregnancy rate and the live birth rate. So it can be used as an alternative treatment before gonadotropins for patients resistant to CC, but further research is required. Rachel et al. Had compared combined use of letrozole and clomiphene citrate, wherein they give letrozole 2.5 milligram along with clomiphene citrate 50 milligram per day for 5 days. And they achieved higher ovulation rate, but definitely further studies are needed to evaluate the effect on the live birth rate. Now, I would like to share my personal experience where we had conducted this study in 80 patients where we had used step-up protocol and extended protocol. And what we found was that there was better ovulation rate and clinical pregnancy rate in the step-up protocol group compared to the extended protocol. Basically, in extended protocol, there is extension of the FSH window. So there is definitely more multifollicular development resulting in multiple pregnancy. Though we didn't have any case of OHSS. We also found that there were more number of mature follicles in the step-up protocol. The time to achieve the dominant follicle was less, and the flow on the perifollicular Doppler were better in the step-up protocol. We went one step ahead, and those patients who had failed with extended protocol, we tried one cycle of step-up protocol in them, followed by time intercourse, and we achieved ovulation in almost 7 patients and clinical pregnancy rate in 1 of them, which is a very small number, but definitely is a positive sign, and further research is required in this area. So concluding, when it comes to letrozole, there is no standardization of letrozole dosage. So larger RCTs are required for the same. Data about teratogenic capacity of letrozole in human is lacking, but so far, whatever the evidence says, there is no major congenital malformations in humans. Coming to tamoxifen, tamoxifen has been used as an alternative to clomiphene, wherein they have been used in the dose of 40 milligram per day. And if ovulation is not achieved, they have been also been used up to 80 milligram per day. Now, coming to adjuvants, they play a very important role when it comes to especially hyperandrogenism, where dexamethasone has a role. Wherever the levels are more, DHEA levels are more than 200, dexamethasone definitely needs to be added 0.25 milligrams at night from day 2 to day 11 of cycle when the patient is undergoing ovulation induction. And Cochrane 2009 has supported this use because it increases ovulation and pregnancy rates when used in combination. We all know the benefits of metformin. It improves the metabolic abnormalities, improves the mitochondrial function, the oocyte and the embryo quality. It improves the lipid profile. It is an anti-inflammatory and anti-angiogenic. And the international evidence guidelines definitely supports the use of metformin, especially in patients resistant to CC with a high BMI. Coming to myoinositol, it increases the insulin sensitivity, decreases the androgen levels, improves the lipid profile, restores normal ovulation, and improves the mitochondrial membrane potential. The dosage is the most important. 4 grams per day is optimal with an MI to DCI ratio of 40:1. Patient compliance is little lacking because of the taste, and the tablets have lower absorption compared to granules. Again, when it comes to international guidelines, they say that inositol is still an experimental therapy. The literature is limited and many key questions still remain unanswered. So now when oral ovulations fail with all the protocols, we can combine it with gonadotropins, where the oral ovulations are given in the start of the cycle up till day 5. And then it stimulates the recruitment of the number of small follicles. And then gonadotropins can be added from day 7 or day 8, which sustains the growth of the recruited follicles. Now, gonadotropins can be used standalone, wherein there are various protocols. So we'll go one by one through them. One is the conventional step-up protocol, wherein the gonadotropins FSH is started at the dose of 75 to 100. And then every 5 to 7 days, there is increase in the doses by 75 international units. Now, this causes supraphysiological doses of FSH. So this is not much a preferred protocol because it may result in multifollicular development and multiple pregnancy. Then there is low dose protocol, wherein we start giving with 37.5 to 75 international units and increase the dose after day 7 by 100%, wherein this mainly promotes monofollicular development. And the chronic low dose protocol, wherein we give low dose of gonadotropins for a long period of time and increase the dose by 50% at around day 14 of the cycle. The only drawback is that the cycles are longer, about 28 to 35 days, but there is reduced risk of multifollicular development and OHSS, and the dose increment is maximum 225 international units per day. And once the dominant follicle is achieved, FSH dose is maintained until it achieves maturity. Coming to the step-down protocol, a high dose 100 to 150 international units is the starting dose. And once the follicle reaches more than 10 millimeter, we decrease the dose by 37.5 to 50 international units. And this results in monofollicular development. And it is more physiological. It mimics the natural cycle, wherein the FSH is higher during the initial phase, and during the later phase of the cycle, the FSH levels drop. So gonadotropins, according to the international guidelines, should be used as a second line of therapy in women who have failed to ovulate with CC or letrozole. And it can be used as a first line treatment as well, but definitely you need to counsel the patient on the cost and the potential risk of multiple pregnancy. But when patients are affordable, it should be given as a treatment form, and definitely it should be combined with metformin with a patient having history of CC resistance. Coming to laparoscopic ovarian drilling, now we all know that it destroys the ovarian androgen forming tissue, followed by fall in serum levels of androgens, LH, and rise in FSH levels. So this in turn promotes the follicular recruitment, growth, maturation, and subsequent ovulation. So it basically restores the CC sensitivity and prevents OHSS. Now the Cochrane review 2010 has clearly said when it comes to laparoscopic ovarian drilling or gonadotropins, what should be the first choice? Now the results are similar. In fact, the ovulation rates are better with gonadotropins. The pregnancy rates are better with gonadotropins. And even in the LOD group, when gonadotropins were added, there were better live birth rates. When it comes to safety and risk factor, as such, they have no difference. But yeah, in laparoscopic ovarian drilling, it has to be done by experts. And in case it is overdone, it may result in complications like adhesion formation and premature ovarian failure. And now the latest reviews, there are many literature showing that it should be avoided in patients with a very high AMH. So definitely we should wait for the 2023 guidelines regarding this view. So it is a second line therapy for women with PCOS who are CC resistant with anovulatory infertility, and it can be offered as a first line treatment if laparoscopy is indicated for any other reason. Now, when all of this fails, we have in vitro fertilization, wherein we give it to patients who are resistant to PCOS or have an associated tubal or male factor infertility, wherein we use the segmented approach. We use antagonist, agonist trigger, freeze-all protocol, and single embryo transfer. So patients should be counseled about the risk of OHSS definitely when there is an ovulatory PCOS history. So according to the international guidelines, it is a third line therapy, but in an ovulatory PCOS, it is an effective treatment, and elective single embryo transfer should be the option of choice to prevent multiple pregnancy. Now, this is a very important point which I would like to bring to your notice, that it is seen that in clomiphene cited resistance, there is FSH receptor polymorphism. So whenever there is a history of anovulatory PCOS or resistance to CC, before taking up for ART, one must rule out FSH receptor polymorphism. So coming to the take-home key points, lifestyle intervention is the most important advice you should give to your patients before initiating any ART treatment, or for that matter, even ovulation induction. Metformin in combination with minoxidil definitely helps in improving ovulation and the clinical pregnancy rate. And there are various letrozole and gonadotropin protocols, though there is no standardization. And hopefully in the 2023 guidelines, they may mention about it. So let's wait for that. LOD, though there are ongoing concerns about its long-term effects on ovarian reserve, it may be used in certain case scenarios, and IVF is definitely the reasonable option, and single embryo transfer should be preferred to prevent multiple pregnancy. So we need to find a balance between benefit and evidence to treat our patients with anovulatory PCOS and to improve the clinical pregnancy rate. Thank you so much, everyone, for a patient hearing.
Thank you. Thank you, Dr. Aditi, for a very crisp talk on such a vast topic, because it is a challenge to treat PCOS, but you have included all the points beautifully. And the last slide exactly shows the dilemma of the clinician, that how to give result without overdoing it and the balance of treatment. Thank you so much.
Thank you.
Are there any questions from the house? But it was a beautiful talk and you covered everything in a very fine way without overloading the presentation. Thank you.
Thank you so much for the appreciation.
Yeah, and thanks for being with us. Dr. Akriti, we'll move on to the much awaited panel by Dr. Patki, and let's invite chairpersons for the panel discussion.
Yes, so I would like to invite Dr. Jyotsna Agarwal ma'am, who is currently the Secretary of Roorkee Obstetrics Gynecology Society. Welcome, Dr. Jyotsna. She's one of our chairpersons. Dr. Surbhi Singh, she's the director and co-founder of Surbhi Hospital for Laparoscopy, IVF, Maternity and Child Care. And she's done fellowship in reproductive medicine and IVF from Hometon Hospital, UK. Welcome, Surbhi ma'am. I would also like to invite our panelists.
We'll introduce Dr. Amit sir first.
I would like Dr. Jyotsna ma'am to please introduce Dr. Amit Patki sir.
Thank you, Dr. Akriti. Warm greetings to all the dignitaries and guests. It's an extreme pleasure and honor to chair this wonderful panel. I'd like to introduce our dynamic moderator, Dr. Amit Patki sir. Sir is an MD, DNB, FCPS, FICOG and FRCOG. He's Medical Director, Fertility Associates, Mumbai. Sir is Honorary Associate Professor.
You can share sir slide, Akriti.
Dr. Akriti.
Or CV slide. Dr. Amit's CV slide was there. Yeah.
Ma'am, it's visible?
Yeah.
Thank you. Sir is Honorary Associate Professor of KG Somaiya Medical College and Hospital. He's consultant Khar Hinduja and Surya Hospital, Khar, Mumbai. He has represented country. He's a country representative Aspire in the year 21-23. Present governing council member COG in year 12 and 21. President-elect ISR in 2022-24, and he is General Secretary MSR 2018-21, Chair West Zone RCOG, and has been President of MOGS in the past. Sir has more than 30 publications in national and international journals, 50 book chapters, and editor of 3 books, 2 international patents in infertility and stem cell research. Sir is also TEDx speaker. Welcome, sir.
Thank you very much. Can I do screen sharing?
Yes.
Yes, sir.
Okay, so at the onset, I would like to thank Aarti Luthra and Akriti Gupta for giving us an invitation. As I told them, I would have loved to be there in person, but God willing, we will come soon, maybe in Sumita Prabhakar's tenure. But congratulations, Aarti and Akriti, despite the COVID and the restrictions. I think Uttarakhand ISAR has done a fantastic job, and we have been kept informed of all the activities. And I was pleasantly surprised to hear your report that you all have participated in most of the major conferences, including ISAR and FOXI. I now would like to introduce the panelist, Dr. Reema Sarkar, who is a consultant at the Indira IVF Dehradun, Dr. Ritu Hinduja, who is a consultant at the Nova Mumbai branch, Dr. Ekika Singh, who is a secretary of OBGY at the Mao Society. And I must appreciate Ekika for the wonderful publications that she has done in the last 1 year. Dr. Radhika Raturi, who is the secretary of Dehradun Obstetrics and Gynec, Aditi Gupta, Ashirwad IVF Haridwar director, Shilpa Sharma, who's at the Vrindavan Femicare at Dehradun, and Nimisha Gupta, who's from the Kala Fertility Center. So welcome to all of you. And we have heard excellent advice from Dr. Durusha. We have heard lectures from Dr. Sujata and Dr. Aditi. And needless to say, we know that PCOS is on the rise. And that is why we have labeled our panel as PCOS through the ages, because it starts from not only the adolescent, but the prenatal stage, as Dr. Durusha has rightly said, that we need to look after the mothers to ensure that we do not have more PCOS born through the years. We also know that in the Indian diaspora, the insulin resistance is present in 75% of our PCOS, which comes as a surprise because we always associated insulin resistance with the obese PCOS. And more worrying is that 33% of our adolescent girls can be classified as PCOS. And I think it is basically lifestyle that needs to be treated. So with these few words, I would like to start with Reema. Reema, to give us a brief of how is the pathophysiology of PCOS? How do you explain PCOS and why it is on the rise?
Right. Good evening, everyone. So PCOS, we all know, we've all read it through right from the beginning of our MD careers, that it has been classically associated with the rise of with hyperandrogenemia. There is basically a rise of androgens, mostly intra-ovarian androgens in these kind of patients. So what actually happens is, yes, as I can see on the screen, there sir has asked about HPO excess. So rightly so, sir, HPO excess does get disturbed, but we cannot really label it as just as one factor. I would say it is a mixture of various factors with various events that are happening at various levels, including the hypothalamus pituitary and the more of it at the ovarian level. So we all know there are this theca cells and the granulosa cells, in which are involved in steroidogenesis classically. So in theca cells, there is mainly the production of androstenedione, that is the androgens from the cholesterol, the entire pathway, and more or less the conversion into the testosterone and into the estrogen is occurring in the granulosa cell. So what actually happens is that there is kind of there is a proliferation of theca cells in this kind of patients, and they become more in number, as well as they become more sensitive. That is, their enzymes also become hyperactive. So these pathways, they are like these events are happening more, so leading to an increase in intra-ovarian androgens. Also in granulosa cells, what is happening simultaneously is that the aromatase activity in these kind of patients, it is kind of reduced in the non-PCO girls or women. And so the conversion of these androgens, which would have normally taken place to estrogen, that is little less. So rise of this comparative rise in androgens and the simultaneous decrease in the estrogen, that is what eventually lead to disturbed signals back to the hypothalamus pituitary, which also leads to then disturbed GnRH pulses. There is more of LH release. The frequency and amplitude of LH releases increase, which further we know as the LH increases, it acts more on the theca cells, which further become overactive, and hence the cycle is kind of started. Correct. Also implicated are various other factors like hyperinsulinemia. More of these patients have more of insulin resistance, which leads to all these, it kind of exacerbates the entire process, along with other intra-ovarian factors like IG, a lot of...
I think you have very beautifully and very simplified it, Reena. But we must understand that the persistent high LH is one of the reasons why there is no recruitment of follicles or anovulation. You have very rightly said that hyperinsulinemia can continue even after the woman has finished a childbearing, and that is the most important cause for metabolic X syndrome. And I think this is one message that I want to give all our listeners, that please keep your PCOS patients under supervision even after they have finished their childbearing, because these are the very women who will land up with diabetes, with hypertension, with cardiac problems, because they will get into metabolic X syndrome. Now, Ekika, tell me, what are the different laboratory diagnoses that you would like to use to diagnose somebody with PCO? And how do you rule out other differential diagnoses, basically like a hypo patient or somebody with congenital adrenal hyperplasia?
Sir, as far as the diagnosis, and since all of us were there, first of all, a very good evening to everyone around, and it's very nice to be part of such a interactive session. Sir, as far as investigating modalities are concerned, it was rightly discussed by Dr. Sujata Kar, madam. I mean, we have to go for, along with the test for the hyperandrogenism, and then the ultrasound, and then the history. So for the diagnosis, I would like to go with the basic routine blood test, in which I would include TSH and prolactin, then glucose tolerance test, which is the easiest one which we do. And then depending upon the history and the clinical symptom, the rest of the test I'll do. As far as, obviously the ultrasound, which now, of course, according to Dr. Sujata, I mean, it is not the center which we take. Correct. So these are the tests which I go through. And then, sir, to exclude the type of differential diagnosis which are there, hypogonadotrophic hypogonadism is the case in which LH and FSH will be low, estrogen will be low. So if I'm having any patient which is having a clinical symptom suggesting of hypogonadotrophic hypogonadism, which again has an amenorrhea as a symptom, so in that case, LH and FHS should be done. These hormones level will be low in these patients, even along with estrogen. Whereas hypergonadotrophic is more in cases of premature ovarian failure. Again, this patient will come with primary amenorrhea. So these patients will have high level of LH and FHS with low estrogen level. So that is if I'm going for the blood investigation. Thyroidism, I have already spoken. Now, congenital adrenal hyperplasia is also, again, has to be clinically seen. Besides the ultrasound, what are the other clinical features? Besides that, in congenital adrenal hyperplasia, it is 17 hydroxyl phosphate, which is, if it is more than 170, then we can think more in favor of congenital adrenal hyperplasia. Insulin resistance and altered glucose metabolism, sir, in personal practice, it is basically what I do is GCT or HbA1c, which is more feasibly done. Yes, there are fasting insulin and which can be fasting insulin and postpartum insulin, which people do, but I'm not very sure about its sensitivity and specificity. And then there is one more called coma index, which are not routinely done. And ultrasound, as we all know, is being discussed.
Yeah.
So
and
that's
AMH is also discussed, but I'm glad, Ektika, that you have said that you don't do insulin resistance. That was a trick thing that I put, because I don't think insulin resistance should be measured, because one thing, it's a very fragile test. The platforms are not very well standardized. It is expensive, so we can go ahead with glycosylated hemoglobin. Or a better test would be to do a sex hormone binding globulin, which is like a surrogate marker for insulin resistance. Important is to check the patient and see for acanthosis nigrans, which is sometimes there in these women. But understand, Indians, 75% of your PCOS patients, whether they're obese or lean, will have insulin resistance. So the question of actually testing for insulin resistance doesn't come, because most of them would need some amount of insulin sensitizers. You have also very rightly said about hypo, when the ovaries look PCO, but the lining will be extremely thin because they have abnormally low FSH-LH. It will be always less than 1, and the estrogen also will be very, very low. Hypergonadotrophic will have very high FSH-LH. In PCOS, it is only the LH which is raised, but in hypogonadotrophic, which is like a premature ovarian failure, we have very small ovaries, antral follicle counts will be low, the lining will be thin, but you will have very high levels of FSH-LH. So now let's come to the practical cases, and let me start with Ritu. Ritu, you have this very young 25-year-old girl who's unmarried, who has a BMI of 28, so she is obese. History of irregular menstruation. She has no hirsutism. She comes to you for consultation, basically for her irregular menstruation. How do you propose to investigate her, and how will you manage her further?
So the fact that she is 25 years old and unmarried, we will probably do the biochemical tests for the biochemical markers, also do a transabdominal ultrasound to kind of come to the diagnosis, whether it's PCOS or if it is something else. I'll try to rule out the other possibilities. If I have diagnosed her with having polycystic ovarian syndrome, then to regularize her periods, because the BMI looks absolutely okay, I don't think she is obese. So I would discuss with her and her family by putting her on some oral cyclical contraceptive pills, or put her on progesterone only pills, whatever kind of, is comfortable after a discussion. And so this is how I would proceed to take it further, because she has no other symptoms. She has no hirsutism, nothing else. It's only irregular periods.
So you would prefer to put her on the OC pills?
Yes, sir.
Yes. Okay. So the reason I put BMI 28 is because by our Indian standards, the BMIs are 2 decimals less than the international standards. So in India, a BMI of 28 would be considered as obese. When you look at the OC pills, would you tell me in detail which OC pills would you prefer? Would you prefer the third generation pills? Would you prefer the low dose? Are there any advantages of those pills?
So sir, I would prefer something with cypriodone acetate in it, because it can actually help me with the hirsutism part of it if there is any. So the third generation is something that I would put
You
her
would
on.
prefer. So they
Yes.
do very well with OC pills, third generation, low dose. Even if they have some amount of hirsutism, so the OC pills are the first line of choice, even if the patients have hirsute. Is all the panelists agreeing with this, or some of them have something else to add? Diti Gupta, would you like to say something? If there is hirsutism, would you straight go on to cyperteron acetate pills, or you would like to try with the birth control pills?
First of all, the pills, obviously, I'll try with sapropteron for the hirsutism patient. But in this case, I mean, with 28 BMI, I prefer her to advise her for lifestyle management, most importantly. So first, she has to reduce her weight, physical activity she has to improve, because we know the most common and the worst reason for PCO and for this thing is obesity, and because of the sedentary lifestyle. So I prefer that young girls should undergo exercises and weight reduction, and then maybe we can add on OCPs.
Okay. Radhika, as an obstetrician and gynecologist, she comes to you for regularization of her periods. You have already told her lifestyle, but her mother is not very happy on her going on birth control pills, because for that generation, birth control pills are meant for sexually active girl, which this girl is not. Is there anything else you can offer this girl to?
Yes, sir. Progesterone's withdrawal is one of the options which are used, and specifically, sir, in the previous case when there is no hirsutism and only menstrual irregularity, I would put her on progesterone only withdrawal pills, and I would explain her and even her mother that this will help her. I mean, giving it for 3 days or maybe for 5 days, she'll have a withdrawal, a good withdrawal. It's that BMI is not pretty high, but overweight, she's overweight. So, I mean, this is the time when it can be told to her, listen, you are on a very thin line. Correct. So probably now is the time that you should think that you have to maintain, you don't need to go up, you have to come down. And progesterone works fine. I mean, this works fine for the patient since she has to take only for 3 to 4 days or 3 days or 5 days regime, not the daily regime. And she'll get a withdrawal.
Okay. Any of the panelists would like to use metformin or myoinositol either together or singularly? Maybe Nimisha can take this question, and then the rest can also answer.
Yes, sir. Thank you, sir, for the question. For hirsutism, metformin studies have been reported that they do in patients with hyperandrogenism. And myoinositol, yes, because it helps in the insulin, it increases the insulin sensitivity. So in this case, along with the POPs, we can advise.
I'm asking you, what will you do? Would you put your patients?
Yes, sir. For her, being she is overweight also, we may start her with metformin.
Yeah.
And the adjuvants, obviously, myoinositol is helpful.
So nowadays, it is better to put these young girls on myoinositol 1 gram twice a day. It helps them to regularize their period. It also reduces their hyperinsulinism without putting them on any hormones that they are worried or their parents are worried. So coming on to the second case, maybe Diti Gupta can or Shilpa can take this, Shilpa Sharma. Now Shilpa, this girl is 28 years old. She has got married. She was diagnosed as PCOS early because of her irregular periods. Her BMI is 30. How do you now manage this patient? She may not be very keen to get pregnant as such, but she wants to at least regularize her periods and lose some weight.
Thank you, sir, for the question. So she's 28 and recently married. We can see that her BMI is on a higher side, which is about 30. And hence, we have to communicate to her that lifestyle changes is something that she has to start at an immediate effect. So she has to start on a weight loss regimen, which would include both weight loss which would be both in terms of exercise and also diet management. So we need to counsel her that how these both are going to help her. And another thing that we need to ask her, that because she is a diagnosed case of PCOS, and has she ever been before on a weight loss regimen? Has she ever tried it before? And if she has tried it before, whether it had helped her in past or not. And hence we have to counsel her on those lines. Also, if we counsel her that this weight loss is going to help her in long term effect, because it's not going to be just a short term goal of fertility and pregnancy, but a long term goal of prevention of the metabolic X syndrome, and hence it may motivate her more in terms of losing weight. When it comes to, because she's here, she's 28, she's concerned about fertility, and so hence guiding her if she has regular cycles or not. And if she does has regular cycles, then we can guide her on her fertility the fertility days, the fertile days. And sorry, sir.
No, go on.
So that counseling has to go hand on hand. So she cannot be just left for for a weight loss management, but a fertility management, if she's really concerned for fertility, would also go hands on together. Then adding metformin to such patients do help, because it has been seen that metformin, if actively tried with weight loss and diet, has also increased the chances that the patient loses weight, and also conception increases. So so the diet counseling with a diet expert, and also our consultation can be done. We need to tell her that she has to decrease her saturated carbohydrates, her fats needs to reduce, less of she has to increase vegetables, green vegetables in her diet. Certain dairy products needs to be restricted or decreased in the diet, because they have been shown association with the PCOS. So all these modifications, also 40 minutes of exercise, if she can do at least 5 times in a week, that's going to help her, which can be a combination of cardiac and cardio and other exercises. So that all has to be guided to her.
Okay, so I think you have covered it up very well. Ekika, this patient comes to you and tells, Dr. Shilpa ne ye sab bataya, maine sab try kiya, but I'm not being able to lose weight. My weight is still stuck at 75. I do walk, I do diet, I do everything. She gave me this metformin, but I was having lot of diarrhea, GI symptoms, so I didn't take it. Although I told her I'm taking it, but I stopped it after 5 days. So how will you now look after this patient who's diet and exercise but doesn't like to take metformin? Ekika, you're mute. Huh?
Yeah. Sir, very difficult to answer for me, because in clinical practice, there are medicines which can be given like statins and other, which are claimed to help in weight loss. But in my personal experience, I haven't used them, so I'm not very much sure whether they really work or not. And then
so in such patients, I have seen that if you combine metformin with myo-inositol, you can do both of them at low doses, but they synergistically work. So you can give metformin, instead of giving it 1.5 grams, you can start with 250 twice a day and build it up to 500 twice a day with myo-inositol. I think that works better. I think quite often they need counseling, they need to talk to you. You need to reiterate the whole thing. I also agree with you that statins and sibutramine and all this is left for the very obese patients, yes, or patients who really are resistant to any treatment.
Probably in these patients, what I generally want to tell them, I would advise them low glycemic diet and more of proteins and more of proteins. That is what I try to build up. I try to give them more of protein shakes so that they feel full, and I tell them to absolutely stop chapatis and rice and everything. Go on if they can eat non-vegetarian, go on more on fish and more on chicken and all those things. So probably they feel more full and they eat less.
For high protein diet,
yes, high protein diet with low glycemic index is what is my funda of telling everyone. Correct. And the rest of the 2 things is only for very obese patient, which because of their obesity are now having even medical ailment attached to it. So these are the ones for the rest of the things.
The rest of the protocol. Rima, let's come to you. This girl is a BMI of 18. she's 28, she's infertile for last 3 years, irregular periods, mild hirsutism. She has visited some of your colleagues who have tried with clomiphene and letrozole, says no ovulation happening. Now, how will you manage this patient who is, as Dr. Aditi has said, she's clomiphene resistant patient? Rima.
So we just heard a very beautiful talk by Dr. Aditi just before this panel, and she gave us various options. I personally, in my practice, I prefer gonadotropins. However, I would now add metformin if it has already not been added, because in a lot of cases, just adding that also helps if they've not been ovulating before. And gonadotropins, I am very comfortable in using. Maybe I'll start not directly with just gonadotropins. Maybe I'll just combine them up with oral ovulagens. But I think this is the right time to switch over to gonadotropins at this point of time, along with metformin, yes, addition of it.
This is a lean PCO. If you can see, her BMI is 18.
18.
Would your treatment differ if she's an obese PCO or a lean PCO?
Yeah, maybe with BMI 18, metformin is not going to help. It is only going to make it more difficult because of the GI side effects. So
but again, understand that lean PCOs can also have hyperinsulinemia and insulin resistance. So your metformin may be a right approach. I'm just wondering that in case if she's lean, thin PCOS with metformin is resistant to oral ovulagens, would you at this stage think about doing laparoscopic ovarian drilling?
In my practice,
you can't tell her to lose weight because she's already thin. You can't tell her ye nahi khao, wo nahi khao because she's thin. At the most, you can put her on metformin and try to reduce the hyperinsulinemia, which will reduce hyperandrogenism, her hirsutism, and see if that works. You're perfectly right in that. But do you think there is a case for laparoscopic ovarian drilling?
So personally, I do not prefer laparoscopic ovarian drilling because she just now compared also, although, when we're getting more of ovulation, we're getting more of pregnancy rates just with gonadotropins, unless I am doing laparoscopy for some other indication as well. So just for a PCO to induce ovulation, I would rather go in for lesser invasive.
I think point taken, but is there anybody else in the panel who would prefer to do ovarian drilling at this stage? Akriti or even Shilpa, Radhika, any views, or you all say that we should go on to gonadotropins? Because both are right. Yeah, Ekika?
Yes, sir. I want your personal experience as far as ovarian drilling is concerned.
Yeah.
We say that follow rule of 4.
Yeah.
4 holes.
Yeah, so you follow rule of 4, or you follow rule of 5, or you follow rule of 6.
No, sir, that is why.
As long as you know that you have to drill less holes with less energy and for the short time, I think that is important because, ovarian drilling can get very addictive. You feel like just drilling the ovary because it is so much there in front of you, and then you overdo it. So I think that is important that we restrict the number of holes. The only reason I would prefer to go for laparoscopic ovarian drilling in this patient is, one is that if the tubes have not been checked, we can check the tubes, one. Secondly, thin lean PCOS have a higher incidence of hyperstimulation than an obese patient. If everything is same, an obese patient has low chances of hyperstimulation, but a thin lean PCOS has an increased incidence, and that is why I feel sometimes it is better to do a controlled laparoscopic ovarian drilling. The effects stay for a longer period of time. You're not subjecting her to hyperstimulation. But I understand that even if somebody goes ahead with low dose gonadotropins, that is also right. It's not completely wrong. Which gonadotropins would you prefer, Ritu? Would you use recombinant or urinary or highly purified, or what is your choice? Or does it matter?
So it doesn't matter.
It doesn't matter.
It does. You can use whatever matter.
Yeah, it doesn't matter. I think you're quite right. One line answer is it doesn't matter. However, I've seen that patients who have got persistently high ALH levels, we need to bring those ALH levels down. Only then there is going to be recruitment of the follicles. That can be done by putting them on OC cycles the previous time, or putting them on antagonists for a few days before you start the gonadotropins treatment.
So sometimes also PCO women can be resistant to HMG stimulation. This is what I've seen. So if in past they are resistant to the HMG that has been already used for them, then I would prefer using a recombinant.
Yeah. So sometimes, as in the talk they spoke about FSH polymorphism. I think now the test is available, but it was not very freely available, and such resistant cases, it may be worth. We have to understand that we have to cross the FSH level threshold to get any stimulation, and that is the reason sometimes in obese PCOS, more often you may want to start with a higher dose than what you would have done in a thin PCO patients. This is another patient which I wanted to highlight about how treatments can happen. A 29-year-old with PCOS undergoes ICSI for severe male factor. Prior to starting, her antral follicle counts are documented as 12 on each side. She started on the antagonist protocol, and then she's given 225 units of FSH for 10 days. On the day of trigger, her E2 is 6,000. She's triggered with HCG. They collect 22 eggs and they do an embryo transfer on day 3. Now, anyone, maybe we can start with Shilpa. Shilpa, do you think there is any fallacies in this patient?
So we can start with the protocol that was used. So the protocol used has been an agonist protocol. And we know when we start the agonist protocol, the trigger has to be an HCG. And hence, now the preferred protocol for the PCOS patient is the antagonist protocol. And we do the agonist trigger, and we try and freeze all the embryos, and we do defer the embryo transfer. The other protocol that is now on talks is the PPOS, or the progesterone primed ovarian stimulation, which can be started or offered to this patient. And the advantage being that there is a less number of injections that would be provided. And as we would be going for an agonist trigger and a freeze all in the end, and hence that would also be another preferred protocol. So these are the two things that we can help this patient with. The other thing is using a lower dose of an FSH or a the Recomb FSH or the HMG for her. We could start with 150 or 187.5 IU, which I usually prefer in a patient with PCOS, is the other thing that we could have changed. But in a PPOS patient protocol, because the level of the gonadotropins that are needed to stimulate would be higher, so maybe we could step it up at 37.5 if we're using a PPOS protocol. So these are few changes that we can do. And so that is a protocol, the dosage, and the trigger and deferring of the transfer. So those are the 4 things that we can start with.
Okay. So now this patient has the transfer. 4 days later, she comes with breathlessness. Both the ovaries scanned are very large, more than 8 centimeters. There is minimal fluid in the pouch of Douglas. The sonologist also says that there is bilateral pleural effusion. There is hemoconcentration. Obviously, the hemoglobin has gone up, but the platelets and total protein are normal. Nimisha, how can you now manage this patient? Nimisha, is she there?
Yes, I'm there.
Okay.
So this seems to be a case of mild to moderate OHSS. She's going into hyperstimulation because of the PCO. So we should admit her and keep her under observation or vital monitoring, and we can start her on enoxaparin, and we may even keep a count on her this respiratory rate and get a pleural this for pleural effusion, and repeated X-ray and ultrasound. This may be required.
Yeah.
Symptomatic treatment for OHSS.
Anybody would want to give colloids like
Yes.
plasma
Yes.
or proteins, albumin?
Albumin
do
is advised to
Yes, sir.
transfer. Yeah.
Yes, sir.
Prima?
Yes, sir. The basic pathophysiology they say behind OHSS is the increased capillary leakiness. So because of the increased VEGF that is there, so I would prefer, so what is happening is they are unable to retain the fluid in the intravascular compartment. So colloids would be preferred because of their size. They would be able to, decrease all these symptoms of hemoconcentration and altered these electrolytes and renal parameters. So yes, I would prefer to give them colloids with a strict intake output charting. Sometimes I've not actually given, but theoretically, albumin can also be given because that would also do well.
So you can give them albumin, you can give them hydroxyethyl starch.
Right.
Previously, we used to give them fresh frozen plasma because we didn't have albumin ready. So all these things will increase the intraosmotic pressure and try and reduce the leakiness, or even try and get some fluid back into the system. But if there is ascites of more than 1.5 liters, or there is pleural effusion of more than 1 liter, I think it definitely needs to be tapped, because that will give symptomatic relief. And when you tap the ascitic fluid, you increase the flow, the reverse flow, and you will get a good cardiac output, and your cardiac and your heart rate will come down. Radhika, assume you are not practicing infertility. This patient has been treated in my clinic, has gone back home to Dehradun, and comes to you with hyperstimulation. You're not a fertility specialist. You don't have much facilities. How will you manage this patient? Even getting a sonography, you don't have a sonography machine in your own place. So is there any basic test that you can do to manage this patient? Radhika, if you're there.
So I think I'd like to again evaluate her symptoms as to what are her main complaints that she's come to me, and I'll at least like to do some basic blood tests.
Correct.
I'd like to check her HCG levels. I'd like to check her hemoglobin, her CBC, her liver functions, her coagulation profile, and definitely the nearest the sonologist I'd like to get in touch with and at least do a baseline scan.
Right. More basic is pulse.
Right, the hemodynamic evaluation.
Gives you a very good indication of the severity. The pulse is less than 100, it is mild. If it is between 100 and 120, it is moderate. If the pulse is more than 120, you know that this patient is severe OHSS, because the cardiac output will reduce, and because the cardiac output is reduced, there will be tachycardia in this patient. So minute you tap the ascites or you give any colloid or something to this patient, the pulse rate will dramatically start coming down, and you can assess these patients. And a basic test like CBC, because if you know her baseline hemoglobin and you find that the hemoglobin has gone up, you know she's hemoconcentrating or hematocrit, and her WBC counts. If the WBC counts are less than 15,000, you know that the patient is mild to moderate. Between 15 to 25, she's moderate to severe. And if she's more than 25,000, it is critical or severe OHSS. Understand that this is not infection. You don't have to give antibiotic. This is like a reaction that this patient is exhibiting. And I think it is very important that every gynecologist should know what to do in a case of OHSS, because sometimes the patient may not go back to the IVF center, but may actually come to you in the middle of the night with breathlessness and abdominal distension. So, Aditi,
Yeah,
when would you
one thing just wanted to add.
Yeah. Go on.
Just that's what saying. Abdominal girth is more important for gynecologists who don't
Correct.
practice IVF. They have to see that. They have to see the urine output of that patient, which is very important. Sometimes they miss. So maybe if they want to put the Foley's, but not Foley's actually will work, but actually urine output has to be taken care of. And actively let them have a physical activity a little bit, maybe leg exercise, physiotherapy, so that the activity of the body activity should go on. So that those things are normal gynecologists should take care of it.
Absolutely. I'm glad you brought out these points. Also, tell me, Diti, when would you admit such a patient?
I prefer, sir, in a moderate to severe, I do ask the patients to admit those patients, because once they have pleural effusion and difficult in breathlessness, maybe for a day or so, once the symptomatic is relief, or if they have abdominal ascites where they have abdominal distension, which may come into mild to moderate kind of OHSS also. But for the symptomatic relief, I do a tapping in a rare cases, but I do. But we have to tell them that it may come back again.
Correct.
It is not a permanent solution. We just have to do a symptomatic.
Yeah, it gives them dramatic
relief.
And they're really happy.
Yeah.
So you will have to admit them. If oral pain killers are not working, they cannot maintain intake, adequate fluid intake, because they're constantly bloating. Or if they stay very far off, then to monitor such patients becomes extremely difficult. And nowadays, it is very easy because all patients have the pulse ox at home, because thanks to COVID. The first thing you tell them is to put the pulse ox, take their pulse and their oxygen saturation. So even before the patient arrives to your doorstep, you have an idea of how severe she is going to be. But it is something which I'm glad Aditi has brought down all the salient points. We now come to a different scenario. Patient of 120 kgs has tried everything that Radhika and Ekika have told her. Walking, dieting, high protein, low glycemic index, yoga, acupressure. She says, now doctor, nothing is working. I'm fed up. Now you tell me what to do.
Considering her weight, I think she falls in the category of obese, either 2 or 3, preferably 3.
Correct.
And I'd love to also understand the fact, does she have any associated metabolic disorders or not?
She's hypertensive now, she's become diabetic, so she has comorbidities.
So definitely we can give her an option of a surgical option for bariatric surgery. If again, I think we will have to have some backup of evidence from the family members that whatever she's accepting that she's done, she's made efforts to it, has actually not,
frankly, at 120 and 140 kgs, they can't even move. Even if the mind wants them to move, no, they cannot move. They get breathless. They have other comorbidities. So I've seen patients at 140, 145. They want to do everything, but they can't even walk because they are so big and they get breathless. They have got sleep apnea. So they have lots of other medical comorbidities. So bariatric surgery is something, as they say, if the BMI is more than 40, or if the BMI is more than 35, but with coexisting medical problems, there are various different operations. They lose 30, 40, 50 kgs over a period of 6 to 8 months. But importance is that they don't try for a pregnancy at least for 12 to 18 months, because they have a large amount of micronutrient deficiencies. And we have seen that a large number of them land up with IUGRs in pregnancy. So does anybody have any experience with bariatric surgery done for their PCO patients? So the most...
I have seen a couple of, sorry.
Yeah,
I've seen a couple of, when I was in Cochin, I was in Cochin with Dr. Hafiz Rahman. So they used to do a lot of bariatric surgeries for these kind of patients. But obviously, they didn't land up to me for IVF at that time. But I've seen that complicated surgery and then even some complications. Some people are very happy. Couple of patients, they do complain that they can't have samosa after that.
Yes.
But that's really good. So many patients, they are really very happy with that.
No chole kulcha and all those things because their stomachs are so small. But what is more common in our country, sleeve gastrectomy, where they cut off almost 80% of the stomach, but which is more better actually for patients who are desirous of pregnancies, gastric banding, because these bands can be loosened up in pregnancy. They can eat as much as they want in pregnancy. They don't get IUGR, and these bands are adjustable bands. You have the ports outside and the patient can adjust the bands. And I think that is something which is more practical in young patients who are desirous of pregnancy, because sleeve gastrectomy is quite a radical surgery. But more important is that they don't go for any ART treatment for at least 18 months, and weight loss has to be gradual, but they lose almost 50-60 kgs. I've had a patient who has lost almost 45-50 kgs after bariatric, and we have had a series of 12 patients who have had a bariatric surgery and then conceived. Most of them, unfortunately, have had sleeve gastrectomy. Only 2 patients have had gastric banding, but the gastric banding patients do extremely well. So I would like to conclude. I think most important is weight loss, talking to them about weight loss, diet, exercise. Combinations of metformin and inositols work well. Letrozole is the first drug of choice, followed by gonadotrophins. In some patients, we may prefer to do ovarian drilling. If we have to go for IVF, it has to be the antagonist protocol with agonist trigger, freeze-all, because only then can we go towards an OHSS-free clinic and then go in for pregnancy. We know that use of metformin in early first trimester not only decreases miscarriage rates, but also gives you very excellent live birth rates. Look for gestational diabetes in these patients, and also be careful of preeclampsia. I think I've almost finished, but important, as I said, through the ages, in the perimenopausal age, it is important to keep these patients under supervision. Again, diet, exercise, micronutrients, and screen them for early diabetes and hypertension. Before we end, I would like to get all my panelists, and I would like them to, each of them, to give one take-home message to our listeners. So let's start with Rima. Rima, what is your one take-home message about PCOS? It could be in infertility, because that's what you do.
Sir, I think educating these patients is very important. Take out time and talk to them, because what I see in my practice is most of these patients are baffled, running from one clinician to the other. एक डॉक्टर ने 2 महीने दवा खिलाई, 3 महीने ठीक नहीं हुआ. So they're all looking for, questions that are unanswered.
They're also looking for quick fix. So that is something that we need to tell them, that this is an ongoing battle. It's a lifelong battle, and they have to understand that they have to take care for their full period of life.
Right.
Very
and take help whenever needed. Right.
Ritu?
So the thing is that I would emphasize on lifestyle modifications. I would emphasize on inculcating a form of exercise in their routine life. And it is not only to achieve pregnancy, but also to, kind of avoid any cardiovascular and metabolic syndromes in the future. So that is something that I absolutely insist with my patients with polycystic ovarian syndrome, that even if they conceive, even if they have overcome their fertility issues, lifestyle modifications, they cannot deviate from there, because that goes a long way.
Absolutely. Ekika, see?
Sir, what I would say, tell them, okay, you might have inherited it or you might have got it because of your lifestyle, but it is preventable if you can put some wills, some effort, some strength. So some mental strength, some willpower will help them go through and sail through.
Perfect.
And that they have to carry on lifelong.
Positive approach, I think, makes a long way. Radhika?
I'd like to work on two ends. On the patient end, I'd like to tell them, since it's a multidisciplinary, involves a lot of multiple problems, I'd like to educate them on the fact that it is controllable, but cannot be eradicated completely by just sitting and not doing anything. And I'd also like to enroll with me a dietitian, a counselor, an endocrinologist, so that we as a team, it's not just one-on-one dealing. They have multiple people they can, pop their questions to.
Aditi? Aditi Gupta?
I think everything. Am I audible?
Yes.
Hello. Yeah. I think everybody has covered everything, but I feel these PCOS patients, mostly they come to us with pimples, with hair growth, hirsutism. So we have to counsel them for cosmetic treatment also, that they have to may undergo the cosmetic this thing. And family support is most important, because most of the time if they are obese, they are into too much of social pressure.
Correct.
So we have to tell them not to do body shaming.
Point. Yeah, you have brought out a very nice point of low self-esteem, and especially these young girls. So it's very important that in addition to all this, you also tell them about care about skin and cosmetics, so that they look good, and that actually makes them feel good also. Shilpa?
Yeah.
Sir, if you're talking about a take-home message, everyone is talking about the patients. So I'm going to talk about doctors. So we have to follow OHSS free clinic, so that a fatal complication of OHSS can be prevented, and we should not be a contributor to the OHSS scenario in our country.
Okay, and Nimisha.
Yes, sir. So I would like to say again the take-home message for the doctors that we see in our IVF clinics, that all patients are coming with only the ultrasounds with PCOS, but they are not clinically or biochemically into that categories or whatever we have learned today. So those diagnosing PCOS, I think that should be again revised as we have learned today.
Absolutely. I think that is very important. At some stages we overdiagnose, and at some stages we underdiagnose and miss some PCOS. So it's extremely important that we keep an open mind, and I think we don't have to be judgmental. I think we have to be constantly encouraging them. Many years back I'd gone to a clinic in Kyoto in Japan, where they do the world's largest number of IVF cycles. And there they had a floor where there were 3-4 different programs. So one was a gym, one was meditation, one was an acupressure and a spa treatment, and there was something else. So, the patient had to enroll in one of the programs because they felt that the PCO patient has a lot of stress and they need to do either one of these three things, either meditation, either exercise, or have these massages, so that they de-stress themselves. And believe me, those patients had fantastic outcomes as far as IVF. So I think PCOS is multidisciplinary approach. It is multifactorial also, and it affects not only from adolescent, it can go up to perimenopausal and menopausal. And I'm glad my panelists have answered all the questions, and they have given so many good suggestions. So I really would like to thank Aarti and Akriti for inviting me to this webinar, and hope to see you all in person. I invite you all for the RCOG conference that is going to happen in Mumbai, 4th to the 6th of November. Would like to see many of you come there. We are having at least 14 RCOG officers coming down, including the president, the 5 vice presidents, and lots of foreign faculty, not online, but physically present in the conference. And it is going to be a 3-day affair. So please, please, please come down, present your cases. And I would like you all to encourage all your junior doctors, because I think the MRCOG exam now has become very easily accessible. All the 3 parts are happening in India. So I think we should be there to see how our juniors appear and do in their international exams. So thank you very much. And I would like to hand over to the host.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir. I have to say something. I am at a place where a lot of NRIs are there, NRI Sardars. So I have had the honor of delivering 3 patients who have underwent bariatric surgery. They didn't get it, they got it done from Chandigarh and Delhi, and one of them conceived with my treatment, simple IUI, and other 2 conceived on their own. And to add to this, we have a gym close by and a dietitian also close to our hospital. And this diet management and this lifestyle management is working wonders.
Yes.
Whosoever have got enrolled, they get pregnant on most of them, especially. And sir, I would like to say that nobody has discussed about on the day of trigger to prevent OHSS. Can we give letrozole?
Yeah.
7.5 milligram letrozole.
Even Caberlin
can be given.
Yeah, Caberlin given for 7 days works extremely well. It doesn't
vaginally,
pregnancy. And we routinely give it to our patients whom we suspect would land up with hyperstimulation.
That is after pickup. But when we give the trigger, can we give letrozole?
When you give the trigger, if you want to give letrozole, for what?
On the day of trigger to prevent OHSS.
At the start, some people do use letrozole to keep the estrogen levels down, but we have not tried it on the day of the HCG. But at the start of stimulation, yes, we have given letrozole to keep the estrogen levels down.
We give it on the day of pickup.
Throughout the stimulation, and it is done in delayed stimulation patients. But given on the day of the trigger, I don't think it will have much effect, because hyperstimulation will happen with HCG. And if you give HCG, you are starting the VGF2 alpha receptors get stimulated. So I don't think it will work unless if you give them GnRH agonist or you put them on antagonist. Then it is possible.
So probably even if you are giving them progesterones after the pickup, that also helps to, ma'am, all these things lowers LH and FHS.
Correct.
So once the LH and FHS is lower, your the flare of OHS is decreased. So generally what we do, since I give a MPA protocol to these patients, so I continue that, and they have a withdrawal bleeding also, and there is nothing to worry about.
Perfect.
Otherwise, it can be given. Antagonist and MPA and cabergoline, these 3 things are wonderful.
Cabergoline works very well. Very well.
Thank you so much, sir.
Sir, it was an excellent webinar. So your questions were excellent. Actually, your questions are very good. Covered everything, sir.
Thank you.
And Amit sir, you have to come to Dehradun.
Yeah, I want to. Koi bulata nahi hai.
Well, we are inviting you right now. Give us a date.
I'll call you to Mau also, which is a very small place. I mean,
Aarti has been saying for the last 1 year that before she hands over, she wanted to invite all the office bearers of ISAR. But I promised Aarti, I said, even if you hand over to the next person, for you, we will definitely come down, because I really want to come to Uttarakhand. I've come as a tourist, but coming to somebody whom you know is different. Coming to some local is completely different than coming as a tourist. So I will definitely come down to Dehradun, Mau, because these places are really, in my mind, like dream places. So I really love to come.
And this is the best time. Once your RCOG conference is done, then you plan it for a break, sir. Give us a date when we invite you, sir. And thank you so much.
Abstract session is on for RCOG conference?
Yes, the abstracts are till the 15th of October.
Oh, that's great, sir. I'm going to put my the next time.
Thank you, sir. The panel was very nice. It covered all the points, and I know all the experts were sitting so alert because the discussion was very good. Thank you so much for sparing so much of time to be with us.
When I heard all the cases, enjoyed.
Wow.
Ma'am, your lecture was an eye opener, specifically for the scans. Absolutely a bang on, ma'am. Maza aa gaya.
Thank you. Thank you.
There's so many things. There were query on ma'am, aapka puchi, that was definitely a very big query when they don't have hyperandrogenism, and there is when they don't have any of the symptoms. Only PCOS का खाली picture आता है, ovary का multiple follicles आता है, and the radiologists give them कि
Give them a diagnosis. Yeah.
And specifically in 3-tier cities, it is so common. Any young girl who is having no menstrual irregularity, no hirsutism, but a scan with these kind of a finding is being labeled PCOS, and she knows कि अब तो उसको PCOS हो गया, अब तो गई वो काम से. That is the thing which we really face.
Yeah.
Very true. Every multiple bulky ovary is being
There
labeled.
was a lot of push and drive to change the name. To reproductive endocrine disease syndrome, but it didn't happen.
Sujata, as president of ISAR, now you must hold some meeting in Uttarakhand.
Yes.
Yeah, we can. We'll get a good attendance because the communication is not very difficult, especially from Mumbai.
Absolutely, absolutely. And from Mumbaikars love to travel. I can tell you that. They'll all come. They'll all come there.
Yeah, sure, sir.
Thank
Dr. Sujata, thank you so much for the idea for the webinar,
Lovely.
the installation ceremony, and for a beautiful talk and for being with us all through. Thank you so much.
Thank you. Hello, good night.
Thank you, and I would like to invite everybody to Uttarakhand, and whether Dr. Aarti is a part of ISR, she's our founder chairperson. So please do visit Uttarakhand, and we'll have a joint combined meeting, and her support is always with us.
Thank you, Sumisha. Thank you.
Big thanks to Walter Bushnell also for a very smooth relay and uninterrupted webinar. They are always a great support, and most of our X-Files, they were done with Walter Bushnell only.
Okay.
Thank you so much.
Thank you.
So thank you so much, ma'am, for giving us this opportunity to indulge in this wonderful scientific program. Thanks to Society, both the speakers, Dr. Aditi Trivedi, Dr. Sujata Kar, for the wonderful talks. It's been an honor to be associated with this scientific program. Thank you so much, ma'am.
Always good to see Ritu, Oli sir.
Thank you, Aarti ma'am. I was waiting for him to finish. So thank you. Thank you for giving me this opportunity. Thank you for making me a part of this panel. And thank you for letting me witness the handover. And I wish all the very best to the incoming team. And I look forward to coming to Dehradun very soon because, we will definitely do something.
Yeah, most welcome.
Thank you, ma'am. Thank you so much.
Thank you, Dr. Surbi, Dr. Oli, for being with us.
Bye. Good night.
Okay.
Thank you, everyone.
Yeah.
Okay, Aarti ma'am, I'm ending the meeting for all.
Thank you, everyone.
Bye.